Hey guys, thanks for joining me here. We'll be talking about hip arthritis today. I'm excited to have everybody here for the first part of our six-part series talking about hip arthritis. Today we're going to focus on non-surgical care. And my name is Dr. Timothy Alton. I'm a board-certified orthopedic surgeon. I practice at Proliance Orthopedic Associates. I did 2 fellowships. I did fracture and trauma care up at Harborview Medical Center as one of my fellowships, and then did a second one in joint reconstruction, which means hip and knee replacements, and did that at the Mayo Clinic, and then was also down in Tampa, Florida for a bit. So had the opportunity to travel around the country and learn how to do this stuff. I'm really excited for the opportunity to talk with you guys about hip arthritis. And my goal for this series is to kind of take you from the very beginning of what is hip arthritis and what are some of the things we can do for it that are non-surgical, all the way through talking about some hip preservation things. And I'll have one of my colleagues joining us, Dr. Sean Halleman, for that. We'll do a session showing you some of the intraoperative tools that we use for hip replacements, talk about what the recovery is like afterwards, and hopefully give you a complete view as to what hip arthritis is and how we can help you with it. So we're starting out tonight talking about non-surgical care. So we're going to start with just some fun facts here. Arthritis is really common. 23% of all the people in the United States have it. That equates to about 54 million people. So if you have hip arthritis, you're not alone. And of those patients who have hip arthritis, 24 million adults are limited in their daily activities from their arthritis. So that means 1 in 4 people has arthritis, and 1 in 4 people with arthritis report severe pain and limitations from it. As you could expect, that's a lot of people, and that's a big expense for our healthcare system, up to $140 billion in direct medical costs each year, looking after people with arthritis. So we have a guest appearance here, starting things out right. You should know I have 3 little girls, and the one in the stripes, that's Stella. She's 5, and that's her sister Paisley. And there's another little girl, Lottie, but she's only 2 and she doesn't know the song yet. But I was sitting there this weekend and I wanted to think, boy, how can I explain to everyone that arthritis is really common? It impacts not only the hip joint, but also all these other joints, knees and ankles and feet and shoulders. And so Stella and Paisley provided us with a little song. All right, good job, girls. And so that just illustrates the fact that arthritis impacts most joints in the body. And I personally, in my practice, focus on hip arthritis and knee arthritis, but it does happen in the shoulders and elbows and wrists and neck and back as well. So common condition, affects a lot of different joints. Now, focusing on the hip, I wanted to take a minute and explain just what normal hip anatomy is. So this is a very basic picture, and it shows that the hip joint is made out of 2 bones, the pelvis bone and the femur bone. And those bones come together at the femoral head, which is the ball, and the acetabulum, which is the socket. So ball in the socket joint, the femoral head sits nicely inside of that socket. And in this drawing, you can see that there's a blue-white coating on the ball and in the socket, and that's called articular cartilage. And so that cartilage coats the ball and it coats the socket, and that cartilage is what allows the hip to move in all sorts of different range of motion activities. And it's a nice, smooth, gliding surface that lets you stand and sit and walk and do all of your activities without any pain. And when that cartilage wears away, that's called osteoarthritis. Now, Dr. Halleman, I mentioned him a bit earlier. He's one of our hip preservation specialists. And this is a picture from one of his operations that he shared with me of what a normal femoral head looks like. So this is when he made a little poke in the skin and put a camera in there and he's looking around. And the thing that looks like a cue ball, that's the femoral head. And that white substance on it, that's the articular cartilage that protects that bone. And that's just what it looks like in real life. So thanks, Dr. Halleman, for sharing those images. Now, when it comes to osteoarthritis, we're talking about a spectrum of disease, all the way from normal to severe. And so this is a visual representation of what a normal hip looks like if you were to slice it and take a look at it in cartoon form. So the blue is the articular cartilage, the coating, and it is the protector of that bone. And what happens is as it wears out, it starts to fray, sort of like your blue jeans do, that favorite pair of blue jeans that you wear. And with time, it frays and frays until pieces start to break off, and then some of that exposed bone underneath starts to hurt a bit, and that's what we call moderate arthritis. And then it gets all the way to the point where you have exposed bone with no cartilage or no cushion on it. And so when I say it's a spectrum of disease, what I mean is that you don't go from a normal hip to severe arthritis overnight. It's a elongated progression as that cartilage wears away over time. And then once you get to the severe side, this is what it looks like. So comparing this to Dr. Halleman's intraoperative image, this is a femoral head that was removed when I was doing a hip replacement surgery. So this is what it actually looks like. That hand is my scrub tech's hand holding it there, but what you see is that there's no cartilage left on this thing. It's been ground off, and it doesn't really look like a ball anymore. It's sort of smushed and flattened, and there's bone spurs, which are those bumps around the edge. And you can imagine that with this being the ball of the ball and socket joint, that when that thing tried to move, or you tried to move your hip, you get some grinding and catching and popping and pain because there's no cushion left on the end of that ball. So when it comes to hip arthritis, I get this question a lot. It's like, why is this happening? Why did this happen to me? And I put this graph on here to illustrate, and this is with total knee replacements, but it applies to hip replacements as well. This is a bar graph that shows not only is this becoming more common, which we talked about, but the dark part of the bar on the very right part of the screen where it says 57%, that's patients over 65 years of age. And what I want to illustrate here is that the majority of people who get joint replacements are over the age of 65. So when it comes to wear and tear, age matters. So it's like the longer you've been around, the longer you've been walking, and the longer you've been using your joint, the more likely it is to wear out. There are a subset of patients who obviously get their joints replaced sooner, but age plays a big part of why it happens. The other reason is you can blame your parents because they gave you your genes. So you blame your mom and your dad for the genes that you got. And what those genes do is they basically decide how resilient your cartilage is, or how strong it is, how much wear and tear it can take. I mean, we all know people who are into their 90s and they have basically normal hips and they never had them replaced. And we also know people who are in their 40s and 50s and have to have their joints replaced. And so there is a factor of it that is genetic. So it's age, it's genetic, then it's also what happens to you during your life. So I'm a big football guy. I've included two pictures here. The one on the left is Bo Jackson, and the one in the middle is Tua, who was the quarterback for Alabama this year. And you guys may know that Bo Jackson was one of the best athletes of all time, former Auburn graduate, but he dislocated his hip on this play and was never the same afterwards. And so a dislocation is when the ball, like a normal, this is just his normal hip, right? And it just popped out a socket, and they put it back into the socket, but the blood supply to that ball was compromised. And when you don't have blood supply to the ball, it basically just shrivels up with time. It's sort of like having a plant in the middle of your garden and you don't water it. It just sort of shrivels away with time. And unfortunately, that's what happened to Bo Jackson. So genetically, I would say that he was pretty gifted. And age-wise, he was pretty young. But because of that injury, he actually had to have his hip replaced. Hopefully, that doesn't happen to Tua. But the illustration here is just that the trauma and the events that happen to you impact how long that hip will last. So now putting on sort of the trauma hat, if you look at the far right side of the image here, that's a CT scan. And that's a patient who is in a high-speed motor vehicle collision, and their socket actually got broken into a whole bunch of little pieces. And so in spite of putting that back together, even if you get the jigsaw put together perfectly, there's been a lot of force that went through that hip that's going to make that cartilage not last as long. So trauma and what happens to you along the way matters. The other thing that matters is your weight. And this is a truck on little tiny wheels. So this is a big giant truck on little tiny wheels. And that's sort of the best analogy that I could come up with for if you are really, really overweight and you're carrying extra weight, that it's just stressing those wheels more so than they're designed to carry. And so obesity matters too. And so losing a little bit of weight can not only help your knees or your hips to feel better, it can help them to last longer. And then finally, the way your hips are formed matters. So this is a cute little baby that has a special cast on their legs to help keep the hip ball pointed right in the center of the socket. And this is treating a condition called dysplasia, which just basically means that the hips weren't formed properly. So if you happen to be one of these people who has dysplasia, that can increase your risk of having the hip wear out prematurely. And the term dysplasia just means that the hip socket wasn't formed normally. It's a bit abnormal. And so it wears out a bit sooner than it otherwise would. So these are some of the main factors that lead to arthritis. The other thing that I commonly see when I evaluate patients in the clinic is that there is pain that can be coming from a whole bunch of different structures around the hip area. Now, the term hip is a generic term. It's an umbrella term that means that part of the body, sort of illustrated by this person where they're putting their hand, but there's so many different structures there. There's muscles, there's tendons, there's nerves, and there's actually the ball and the socket joint. So I spend a lot of time talking with my patients, examining them, and trying to figure out if their pain is coming from the ball and socket part, the hip joint itself, as opposed to something else around the hip. And when the pain is coming from the hip joint itself, people commonly complain about pain in the groin area. They often have pain with activity, so going on longer walks, using the stairs, getting up and using your hip. The more you use it, then it tends to hurt more. The other thing people complain about is stiffness, meaning, boy, it's hard to get my shoe on, it's hard to get my sock on, and you can kind of always tell the person that's coming in to get their hip checked out if they've only got one sock on, or if they've only got one of their two shoes tied, or they're wearing sandals or something like that, because they can no longer tie their shoes. People also complain about locking in the hip joint and sort of a grinding feeling. The medical term for that is crepitus. And what that is when the hip joint wears out and you don't have that smooth gliding surface any longer, you have those bone spurs that are grinding around and the articular cartilage has worn off, then it no longer acts as a smooth joint. And people don't like that. It usually hurts. And again, less motion is very common. So when we go back to our little picture here showing the spectrum of arthritis from normal to severe, what patients notice is that this is a progression over time and their pain increases as the condition gets more severe. I would say that's pretty logical. The other thing that happens is that your function decreases. And so as it gets more severe, pain increases, function decreases. And people come into the office, and I hear this all the time. They say things like, I can't do the things I want to do because my hip hurts me. And so they commonly go see a primary care doctor first, and they may or may not get x-rays and then refer you on to a specialist, which would be like one of us who does hip and knee replacement surgeries and manages arthritis. And so usually it's when the pain gets to the point where your quality of life is really suffering, that's when you find your way into the office. And that also plays a big part in how we decide whether or not to do a hip replacement operation for you. So when you come into the office and you get an examination, you spend, again, a lot of time making sure that it's actually the hip joint and not one of these other things. So I wanted to highlight a couple of the other conditions that can cause hip pain but aren't the hip joint itself. One of the really, really common ones that I see is called trochanteric bursitis. Those are basically just fancy doctor words for saying that there's pain on the side of the hip. And so on the center part of the screen here, I highlighted the two bursa. And so there's a superficial one and a deeper one. And basically, these are little fluid-filled sacs that provide a bit of cushion between some of the muscles and tendons and the bone. And these can get inflamed. And inflamed means they hurt. And so people with trochanteric bursitis get pain on the side of the hip. They get pain when they lay on their side. It's really hard to sleep. And when I examine you in the office and I push in that area and it reproduces the pain, then we think of that as trochanteric bursitis. And that's not the hip joint itself. It's not the ball in the socket. It can be a downstream effect of having hip arthritis, but it's something very different from hip arthritis itself. And the management is commonly physical therapy, stretching, anti-inflammatory tablets, and then doing an injection into that bursa with anti-inflammatory medications. And we can do that in the office and help you feel better. The other thing that there's a lot of overlap between hip pain is back issues. And so the common term is sciatica, and that's when you have inflammation of the nerve. And it's really can be challenging to sort out whether or not your pain is coming from the hip joint itself or from a pinched nerve further up. Some of the key things that we ask to try and sort this out is whether or not the pain radiates. And what that means is whether it shoots down sort of the course of that nerve. And if it shoots down and it goes below the knee, then we often think, boy, that's probably coming from the back. People who get a lot of pain in the musculature or the buttock area, that can be from nerve pain. Or if you're having weakness into the muscles, that can be from a pinched nerve as well. It's also really common that people have both problems where they have a pinched nerve and sciatica and hip arthritis. And so I have a lot of patients. We have a couple of nerve and spine experts here in the clinic, and we share a lot of patients who actually have both problems going on. Another common issue is just having a problem with the muscles and the tendons. And maybe you're been really active lately, picked up skiing, picked up a new activity, and you get tendinitis or inflammation of the tendon. Well, that goes right next to the hip joint, and it can mimic hip arthritis. So we tease out some of those differences based on some of the details of the story that you tell us, and also based on the examination that we do in the office. And then finally, this is a non-orthopedic issue, but having a hernia where you have a little bit of a soft spot in the abdominal wall, and that can mimic groin pain as well. And so these are all just some of the main things that are on the differential when we start seeing a new patient who is having pain in the hip area. And this is something that's really critical, I think, to narrow down that, boy, this is actually coming from the hip joint itself. Last thing you want to do is do a hip replacement for somebody who has a hernia. That's not going to help. So we spend a lot of time being very meticulous about making the proper diagnosis. So once we've made the correct diagnosis and we know that people have pain in their hip joint from arthritis, I wanted to cover some of the things that patients can do to help it to feel better. And one of the main things patients can do is modify their lifestyle. And so if you find that going up and down the stairs is really painful for you and aggravates your hip, and there's an elevator, well, try the elevator. And just make some of those little changes to try to avoid some of the aggravating activities. Switching from high impact to low impact activities can be helpful as well. I think of a patient that I saw recently who really likes running outdoors, and he just can't run because of his hip arthritis, but he found that if he swims, he can swim all day and get the cardiovascular workout that he wants to get just without stressing the joint from running. So some of these subtle activity modifications can really help preserve the lifespan of your hip as well. Losing weight, we talked about that before. Less weight that you carry in your belly or your upper body is less stress that your hip sees with every single step. And I think about, for those of us that have done some outdoor activities, either carried a backpack at some point in your life or done some hiking, boy, it's a lot easier to make it up that trail if you're not wearing a 50-pound pack on your back. So given the opportunity to have a 50-pound pack or no pack, boy, it's going to be a lot easier if you're not carrying the pack. So similar concept for your hip joint itself. And then the other thing patients can do is physical therapy. And what that is basically a structured exercise program to help build the muscles around the hip, improve the flexibilities. And these folks, the physical therapists, we work with them very closely, and they are experts in structured exercise programs. And sometimes they meet with you in the office for a couple of sessions for a couple of weeks, and then they teach you a home exercise plan and can talk to you about the activities that you want to do and what are some of the smart ways that you can get back to doing those activities, and they customize it just for you. So that can be really powerful too. So those are some of the things that patients can do. So what can we do as doctors? Well, medications. So people ask a lot about glucosamine and chondroitin. And this is a safe medicine. You can get it at Costco. You get a big giant tub for pennies on the pill. And I think the take-home message here is that it's safe and it's not going to do any harm. And it maybe helps. There's not great evidence that it's a big game changer for you, but it's not really going to hurt you. So I put that in the category of sort of pretty low risk, and it may be beneficial. Tylenol is an over-the-counter medicine. It's also called acetaminophen. And so Tylenol is the name brand, right? Acetaminophen is the medicine itself. It's over the counter. It's a pain reliever, and it's a cornerstone of management of arthritis. It's not addictive. It's not a narcotic. It's pretty darn safe. It's metabolized by the liver as opposed to some of the anti-inflammatories, which we'll talk about, which are commonly metabolized by the kidney. So it's a great medicine for patients with arthritis, and it can really help eliminate some of the suffering that people have. Over-the-counter non-steroidal anti-inflammatory drugs, NSAIDs or NSAIDs, are non-steroidals. Aleve, Advil, ibuprofen are some of the common names, and these are good to relieve pain, and they actually decrease inflammation systemically. So you take the tablet, and the anti-inflammation medicine slowly sort of increases in your system, and it circulates through your whole body, and it helps decrease some of the pain associated with the inflammation from the hip. It's not a narcotic medicine, it's not addictive, and again, it's metabolized by the kidney. So ibuprofen, very different from Tylenol, completely different class of medicine, works a completely different way, is metabolized a completely different way. The dosing regimen is very different as well. So you can take both of these and you can take them safely, and they work to decrease the discomfort in very different ways. There are some stronger non-steroidal anti-inflammatory drugs that we as doctors can provide. And so if you've been taking a leave for a year and it's just not working anymore, we could try one of the stronger ones as well. And then the steroidal anti-inflammatories such as prednisone are occasionally used, or a type of steroid called cortisone can be injected into the hip joint itself to really get rid of some of that inflammation right at the source. And so that's really the other sort of cornerstone of management that we as doctors can provide for our patients with hip arthritis, and that's an injection into the hip joint. And this is great because it takes medicine and it puts it exactly at the source of all the discomfort. And so we can use a couple of different things to inject into the hip joint. I would say the gold standard is cortisone, and this is a safe medicine, it's effective, and you can repeat it every 3 months as long as it's beneficial. Insurance companies in general cover the cost of it, and it's really cheap, on the order of a few dollars. It's got a really good track record, and I'm also personally biased towards it because it was discovered at the Mayo Clinic where I spent some time, and I actually have the Nobel Prize there at Mayo, and you can see it, and they're really proud of it too. So it's a really good medicine to decrease inflammation, put it right into the hip joint, and get that hip joint back to making normal joint fluid as opposed to all of these inflammatory particles that cause pain. The other thing that's gaining some traction these days is called platelet-rich plasma. And what this is basically you draw a patient's blood, and then you put it in this fancy tube, and you use a centrifuge, and you spin it down, and it collects this special layer of just sort of healing factors and growth factors from your own blood, and then we take that and inject it into the hip joint. And the thought is that what those particles do, what those little growth factors and things do, is it sort of resets the lining of your hip joint back to making normal joint fluid, and it deactivates some of those pain receptors. It costs about $800 to do it though. So it is more expensive than the cortisone, but some of the cool things is that it's basically using something that your body already makes, concentrating just the healing factors and putting it into the hip joint. The third thing that I get asked a lot about is stem cell injections, because it's such a great concept, right? If we could take these cells, a stem cell is a cell that in theory can get turned into any kind of cell, and we can inject that into the hip joint, and boy, if it could heal the cartilage or grow new cartilage, that would just be fantastic. Then you don't need to have a hip replaced at all. And I love the idea of it. The problem is that we're not there yet. There's really no data that this works. There's a lot of companies and folks who will advertise this to consumers, and you'll hear stories about sort of miraculous recoveries that people have had. But what I can tell you is that from a scientific literature standpoint, there's really no literature to support the use of it. In fact, the American Academy of Orthopedic Surgeons actually recommends against stem cell injections. Insurance doesn't cover it. It's really expensive, on the order of thousands of dollars, like a car. And so I tend to counsel my patients really against doing it, unfortunately, at this point. So really, I think the best bets are platelet-rich plasma or cortisone. I spend a lot of time getting patients cortisone injections. Now, the hip joint is deep down inside, as you guys all know, and there are some really important structures that go around the hip joint. There's a big blood vessel called your femoral artery. It's one of the biggest blood vessels in your body. It basically gives blood to your entire leg, and it's right in front of the hip. There's a whole bunch of nerves that go around there too. And so unlike knees where we can just do the injection right in clinic, you need to have some image guidance to do a hip injection. And there's really two ways to do it. My preference is what's called an ultrasound guided injection. And you can do that right in the office. It's cheaper than going to a hospital or a surgery center to get your injection. And you use sound waves to see the hip joint, and you make sure that that medicine goes right into the hip joint, and you make sure that you're not hitting any of those other vital structures along the way. The other way of doing it is a bit more involved, and this is a picture of what it looks like. That's a X-ray machine called a C-arm, and there's a patient underneath of all of those drapes, and what they're doing is shooting X-rays as they're putting the medication in to make sure that it's going into the hip joint, and they're putting it right where they want to put it. A bit more expensive this way, you know, you have to go to a special facility as opposed to just coming to the office. The other thing I would add is that the cortisone can onset really within a couple of days and get you up to 3 months of relief. Some people even see longer periods of relief with a cortisone shot, whereas the PRP can take a little bit longer to onset. It can take a couple of weeks. Some studies say even up to 6 weeks before you're seeing its maximum efficacy, but it can last longer, in theory up to almost 6 months. So, you know, they did this study where they took people that had injections into each one of their hips, one of them by ultrasound and one of them by the X-ray machine. And they asked them, which one did you prefer? Pretty basic study, my kind of science here. And 49 people preferred the ultrasound, and one person couldn't remember which one they liked better. So that's pretty compelling evidence for the ultrasound. And I wanted to put this picture here. This is Dr. Ty Jones. He is one of our non-surgical orthopedists here with ProLiance. He's board certified in sports medicine, and he has a particular interest and skill set at doing ultrasound guided injections. And so he goes to most of our satellite offices, and boy, he's just really fantastic at doing these image guided injections for us. So I tend to send my patients to Dr. Jones, and pretty uniformly, they enjoy him. He's a nice guy, and he's technically very good at what he does. So if you need to have a hip injection, hopefully I can put your mind at ease a little bit. They're really well tolerated, and they can be really effective. Sometimes they're not, and you know, as the disease progresses, sometimes they become less effective too, but it is something that we do commonly for our patients that is a non-surgical way to help treat hip arthritis. So that is the extent of the prepared material I have here. We spent some time talking about basic hip anatomy, what arthritis is, sort of what that disease process does as the cartilage wears out with time and you go from a normal hip to a severe hip. Pain increases, function decreases, staying active is important, taking anti-inflammatory pills, maybe doing an injection. These are all things that we can do to help our patients with hip arthritis that are non-surgical in nature. So what we're going to do now is open it up for some questions, and I'll be available to take any questions that you have about hip arthritis and non-surgical care of that condition. So thank you for your time and your attention, and we'll start answering questions now.